Hello everyone, my name is Biagio Ricciuti. I'm a thoracic medical oncologist at Dana-Farber Cancer Institute, and I'm very pleased to join the OncoAlert Colloquium this year. Today I'll review key updates in advanced non-small cell lung cancer, focusing on major practice-changing or practice-reaffirming data that emerged in 2025. These are my disclosures. And I'll structure this talk around four main areas. First, EGFR-Mutant non-small cell lung cancer. Second, HER2-positive disease. Third, we'll review some updates in squamous cell carcinoma setting. And finally, we review driver-negative non-small cell lung cancer, including biomarker-driven immunotherapy optimization strategies that have emerged over the last 12 months. And I'll start with the updates in the EGFR-mutant non-small cell lung cancer field. As many of you know, for several years, Osimertinib monotherapy has been the standard first-line therapy for EGFR-mutant non-small cell lung cancer, having shown to improve not only progression-free survival but also overall survival compared to the first generation of EGFR tyrosine kinase inhibitors. In 2025, the paradigm of treatment for first-line options and this patient population is clearly shifting. We now have multiple combination strategies that have shown we can potentially improve not only progression-free survival, but also overall survival over standard of care, single agent osimertinib. And today, the key question is not longer whether this combination represents the best-in-class treatment for our patients with EGFR mutation, but rather if there are still some patients who can just benefit from single agent osimertinib alone. And we'll review these two studies showing that two combination strategies can really improve meaningfully the outcomes of our patients. The first study we'll review is the FLAURA2 trial. FLAURA2 is a randomized phase 3 study that looked at osimertinib plus platinum-pemetrexed chemotherapy versus osimertinib alone in patients with EGFR common mutation, X19 deletion, and L858R mutation. The study had already met its primary endpoint of progression-free survival, but importantly, we now have mature overall survival data from last year, and chemotherapy in combination with osimertinib significantly improved overall survival from 37 months with the monotherapy to 47.5 months with the combination therapy for an hazard ratio of 0.77, as you can see in this slide, benefit which was consistently seen across all predefined clinically relevant subgroup of patients. Certainly, this study contributes to establish overall survival and not just PFS as the new benchmark for first-line EGFR trials. MARIPOSA is the second randomized phase 3 study meeting its overall survival endpoint in 2025 in the frontline setting, again in patients with the common EGFR mutation. This study looked at the combination of Amivantamab, a bispecific EGFR-MET antibody, in combination with Lazertinib, which is a third-generation EGFR-targeted therapy. And again, as you can see in this slide, the combination therapy here produced a statistically significant but also clinically meaningful improvement in overall survival. As you can see, median overall survival was not yet reached with the Amivantamab Lazertinib combination compared to 36 months with osimertinib. However, the predicted survival benefit is at least 12 months with the combination strategies, with hazard ratio here fairly similar to the FLAURA2 trial, 0.75, again suggesting a 25% reduction in the risk of death or progression for this patient population. What is striking about both trials, in particular MARIPOSA, is the durability of disease control and possibly delayed onset of on-target resistance that we've seen in correlative studies also presented last year from Dr. Bess and colleagues. But with efficacy also comes toxicity. In FLAURA2, adverse events are largely chemotherapy-driven, as you can see here in the combination arm, with cytopenias, fatigue, for example, among others. And this is somewhat expected. These toxicities are front-loaded, generally manageable, but they do underscore the importance of patient selection, especially in older or frail patient population that we think may not tolerate chemotherapy well. In contrast, MARIPOSA has a distinct toxicity profile. This is dominated by infusion reactions, nail or skin rash, as well as thrombotic events. Now, with the subcutaneous formulation of amivantamab, we have seen a sharp decrease in infusion reaction, but skin toxicity persistent remains a major challenge. We now have prophylactic regimens, including the Cocoon protocol, which include a very aggressive skincare regimen, which can help decrease the risk of grade 2 or higher skin toxicity for our patient population that embark on the journey of treatment with this specific approach. There is certainly less hematologic toxicity than chemotherapy-based approach, but ultimately the decision between these regimens, for example, FLAURA2 or MARIPOSA, is not just about efficacy, it's also about matching toxicity profiles to individual patients. We'll move on to HER2-mutant non-small cell lung cancer. This population has been historically difficult to treat. While antibody-drug conjugates, such as trastuzumab deruxtecan, have certainly moved the field forward, tolerability has been a major limitation. And in 2025, we have seen a true inflection point with next-generation HER2-selective targeted therapies being available to our patients. These are results from the phase 1a/a/b study of Osimertinib. Osimertinib is an HER2-selective tyrosine kinase inhibitor that has shown very high response rate in patients with HER2-mutant non-small cell lung cancer. In cohort 1 of the study showed here, which included patients pre-treated with other systemic therapies, the objective response rate was 71%, with a median progression-free survival of 12.4 months. This certainly represents a meaningful step forward for this population, for which we never had effective and, more importantly, safe targeted therapy. We tried to use irreversible pan-EGFR targeted therapy or irreversible HER2 kinase inhibitors, but those were too toxic for our patients and the response rate was not fairly high. So certainly these represent a major step forward in the treatment landscape for this population. Cevabertinib builds on this momentum. This is a second mutant-selective EGFR-HER2 tyrosine kinase inhibitor that demonstrates robust and consistent efficacy across multiple treatment lines for patients with HER2 mutations. As you can see here, there are multiple cohorts in this study, but I'd like to draw your attention to the cohort F, which includes patients who are treatment naive. And there you can see an objective response rate of 71%, with a median progression free survival that's yet not reached the data lock. But as you can see, in pretreated population, the PFS range from 5 to 8.3 months, again suggesting efficacy of this next generation of targeted therapies for this unique population. Of course, having two drugs is helpful. It gives us flexibility. Maybe cevabertinib may be slightly more toxic given its mechanism of action, with an increase in the skin rash rates, but also possibly increased grade 3 diarrhea. But overall, these two studies have established HER2-mutant non-small cell lung cancer as a distinct and finally targetable disease rather than an orphan subgroup of patients. The take-home message for the HER2 population is very simple and clear. HER2 mutant is now as effective and more tolerable targeted therapies. And so this will now fundamentally change the treatment sequencing and also the design of clinical trials for patients who harbor HER2 activating mutations. Now we'll move on to squamous cell carcinoma. In squamous cell carcinoma, the HARMONi-6 trial compared ivonescimab plus chemotherapy versus standard of care atezolizumab plus chemotherapy in mainland China has demonstrated a significant benefit and improvement in progression-free survival with the combination of ivonescimab and chemotherapy. Ivonescimab is a bispecific anti-VEGF PD-1 antibody that has already shown to be superior to pembrolizumab, again in mainland China, in a large randomized phase 3 study for patients with non-small cell lung cancer and positive PD-1 expression level. And consistently with that study in the squamous cell population here, the combination of ivonescimab plus chemotherapy was superior in progression-free survival, which was nearly doubled with the ivonescimab combination versus tislelizumab chemotherapy, which is one of the standard of care options available in mainland China. This study suggests that combining immune checkpoint inhibition with vascular modulation potentially can overcome intrinsic resistance, and something that we really struggle as a community in patients with squamous cell carcinoma, where we don't have good biomarkers for immunotherapy response, and usually the efficacy of PD-1 inhibition is less compared to what we see commonly in patients with non-squamous histology. Of course, a word of caution. This is a study conducted in mainland China, so we are waiting for the global phase 3 confirmatory studies before we can adopt broadly these new combination strategies or ivonescimab as a new backbone for future immunotherapy trials. Now, moving to driver-negative non-small cell lung cancer in general. In driver-negative disease, biomarker refinement has been very, very challenging. But we do know, and we have long known, that patients with PD-L1 negative expression or patients with loss of function mutation in STK11 have historically done poorly with PD-1 monotherapy and also PD-1 chemotherapy combination. We have data from this year from a large meta-analysis of clinical trials that dual immunotherapy, so combining PD-1 or PD-L1 inhibition plus CTLA-4 blockade, can significantly improve survival in this high-risk population. And we've seen that being true for patients who are PD-L1 negative, as you can see on the left side of the screen here, but also in patients who harbor STK11, also a function mutation. So this data finally supports the adoption or consideration for dual immunotherapy for high-risk population, and again, suggesting that biology-driven treatment selection can really help improve outcome in our patients who have high risk of primary resistance to immunotherapy. But one of the most intriguing studies across all non-small cell lung cancer patients was presented this year and actually published in Nature Medicine only yesterday, examined the time of the day administration of chemoimmunotherapy. This was a randomized phase 3 study looking at treatment timing, morning versus evening. And as you can see here, patients were randomized to receive standard of care chemoimmunotherapy in a ratio 1:1, either to early infusions before 3 p.m. or late infusion after 3 p.m. And patients had to receive the first 4 cycles within those time frames. Primary endpoint was progression-free survival. Secondary endpoint was overall survival, response rate, and then the authors also did several correlative studies to understand if there is a specific mechanism behind the potential association between infusion, time of the day of the infusion, and then immunotherapy efficacy. Well, the study showed that administering immunotherapy early in the day does improve significantly not only progression-free survival, but also overall survival. And the delta we are seeing between these groups is pretty dramatic, with hazard ratios of 0.42 for PFS and 0.45 for overall survival, both favoring early infusion before 3 p.m. So this is remarkable in some perspective because it's a study showing that we do not need new drugs, new biomarker, or additional costs. We can implement easily the approach of immunotherapy in the morning. It's a rare opportunity to improve outcomes through simple, system level change. However, a word of caution again, also in this study, we do not know necessarily the biology behind this association. There are preclinical studies that have shown that the tumor microenvironment might change during the day, and lymphocyte density has a circadian rhythm. So there is a potential reason why we're seeing this association. We need more studies, more also preclinical validation of these findings to broadly adopt early infusion for all our patients with immunotherapy. And this has the potential to apply to other immunotherapy strategies, including T-cell engager in the future. So to conclude, in 2025, for the EGFR-Mutant non-small cell lung cancer population, we have seen how combination strategies can improve overall survival over single-agent therapies. For HER2-mutant disease, we have now a new wave of next-generation targeted therapies, and this certainly represented a major therapeutic shift. We now have, in fact, more effective and, more importantly, safer option for patients with these specific alterations. In the field of immunotherapy, we have seen how bispecific antibodies and dual checkpoint blockade are refining treatment for biologically defined high-risk subset of patients. And finally, we have dedicated study in the squamous cell population showing how, again, targeting the VEGF pathway with bispecific antibodies can be a meaningful strategy to improve outcome. But again, we'll need to wait for confirmatory studies conducted globally. And finally, chronotherapy reminds us that how and when we deliver treatment can matter as much as what we give to our patients. Thank you so much for your attention.